Congenital hip dysplasia, or developmental dysplasia of the hip, is a problem where the socket, or acetabulum, and the femoral head are misaligned, resulting in an unstable hip joint. Typically, the problem is present at birth, but sometimes it appears later as the bones develop over time. The hip joint is a ball and socket type because the ball shaped head of the femur sits and rotates within the acetabulum, which is a cup shaped socket. The hip joint is supported by a tough fibrous joint capsule, which is made up of three main ligaments: the iliofemoral, the pubofemoral, and the ischiofemoral. The main job of the joint capsule is to hold articulating bones together and make sure the joint stays stable when the hip is moving. Now, the acetabulum itself is a combination of parts of three pelvic bones that join together: the ischium, the ilium, and the pubis. At the bottom of the acetabulum, known as the acetabular fossa, arises a ligament called the ligamentum teres that attaches to the fovea capitis, which is a depression found on the tip of the femoral head. This ligament helps with joint stability, especially during hip flexion and abduction. Now, the edge of the acetabulum has a thick, bony circular rim covered by a ring of cartilage known as the acetabular labrum. At its lower end, there's a depression called the acetabular notch, which is covered by the transverse ligament, which fills the gap within the circumference of the acetabulum. Now, the normal development of a hip joint requires that the femoral heads stay fitted within the acetabulum so that they both grow together, keeping their sizes and shapes proportional. In congenital hip dysplasia, the femoral head dislocates out of its acetabulum during development, and as a result, the ball and socket grow out of proportion to one another, so that they're unable to form a normal, stable joint. The cause of the dislocation isn't always known, but one situation that can give rise to the problem is when too much mechanical force is applied against a fetal thigh. It can cause the femoral head to slip out of the acetabulum. This can happen when a baby is lying in a breech position within the mother's uterus, resulting in the baby's buttocks being near the cervix at the time of delivery. This sort of mechanical force is most likely to occur within firstborns, because the mother's uterus is not as stretched out, putting a lot of pressure on the baby's thighs. This can also happen when there's not enough amniotic fluid to expand the uterine cavity so that the fetus can have enough room for its legs. When the femoral head spends a lot of time outside of the acetabulum, the acetabular structures, specifically the labrum, ligamentum teres, and the transverse ligament, start hypertrophying within the acetabular fossa and occupy the space for the femoral head. In other words, the socket becomes more shallow, making it a poor fit for the femoral head. Symptoms of congenital hip dysplasia may differ according to age. Some newborns and infants may present no symptoms, but may have legs of unequal length or asymmetric skin folds around the groin. Older kids may present with painless limping and a waddling gait, and when this doesn't get properly treated, it may develop into painful osteoarthritis in adulthood. The diagnosis of congenital hip dysplasia is based on physical exam. There are several techniques for examining the hip, such as the Barlow maneuver, which consists of adducting the hip while holding the knee straight. And when this pops the femoral head out of the socket, it raises suspicion of hip dysplasia. To confirm the dislocation, the Ortolani maneuver is done, and this consists of flexing the baby's hip at 90 degrees and then gently abducting it. If the femoral head was out of the socket, the Ortolani maneuver will cause it to slip back into the acetabulum, which will feel and sound like a clunk. Also, imaging, like ultrasound and x-rays, can be used to assess the position of the femoral head and the structure of the acetabulum. Now, the treatment of congenital hip dysplasia depends on age and extent of the deformity. Below 6 months, the deformity is usually corrected by holding the hip joints with an abduction splint, such as a harness, specifically a Pavlik harness, that holds the hip joint flexed and abducted for a period of 1 to 2 months. This helps to keep the femoral head within the socket to promote normal hip joint development. If the baby is older than 6 months, reduction under anesthesia may be needed to manually reduce the femoral head back into the acetabulum. If closed reduction doesn't work, surgery might be necessary for open reduction, which is followed by a special hip cast that immobilizes the femoral head inside the acetabulum as it's healing. Alright, as a quick recap. In congenital hip dysplasia, the femoral head and the acetabulum don't develop proportionally to one another, which causes them to misalign, forming an unstable hip joint. Children with congenital hip dysplasia present with legs of unequal lengths and asymmetric skin folds around the groin, and they may develop limping and waddling gaits when they start walking. Below 6 months, congenital hip dysplasia is treated with a Pavlik harness, and closed or open reduction for older kids, and in some cases, surgery might even be necessary.
Legg-Calvé-Perthes disease is a childhood hip disorder that occurs when the blood supply to the head of the femur gets disrupted and leads to death or necrosis of the tissue. The disease was named after 3 doctors, Arthur Legg, Jacques Calvé, and Georg Perthes. The hip joint is a ball and socket type because the ball-shaped head of the femur sits and rotates inside the cup-shaped socket called the acetabulum. This gives the hip joint the ability to move nearly in all directions, as long as the ball can smoothly rotate inside the socket. Now, the head of the femur is supplied by branches of 3 arteries, the medial and lateral femoral circumflex arteries, as well as the artery of ligamentum teres. The arteries send branches that climb up the neck of the femur to supply the head of the femur, providing the tissue with the nutrition it needs to grow and maintain its spherical shape. In Legg-Calvé-Perthes disease, for some children, the blood supply to the femoral head becomes interrupted for some reason, and it's not known why exactly. The result is that the tissue begins to die off, a process called avascular necrosis. Over time, there's new blood vessel formation into the necrotized bone that allows the dead tissue to get removed by immune cells called macrophages. That process causes the head of the femur to lose mass, leaving it weak and prone to fractures. When this happens, the head of the femur becomes misshapen and can no longer smoothly rotate inside the concave acetabulum, which results in reduced range of motion. Now, over time, Legg-Calvé-Perthes disease typically self-resolves, and the bone is able to heal. Once again, it's not exactly known why or how this happens. When bone remodeling occurs, new bone replaces the necrosed bone, and the spherical shape of the head of the femur gets restored and properly fits in the acetabulum again. With time, there's normal functioning of the joint once more. Children with Legg-Calvé-Perthes disease develop a limp and hip pain, which is sometimes referred to the knee. The pain usually gets worse with activity, which may even make the affected hip very difficult to move. This particularly affects abduction, moving the leg laterally away from the body, as well as internal rotation, which is turning your leg inward. Also, because the affected leg is less used, its muscles may become atrophied, causing the leg to look smaller than the normal one. Diagnosis of Legg-Calvé-Perthes disease mainly involves taking x-rays of the hip, which reveal a flattened and misshapen femoral head. In addition, an MRI can be done to see the shape of the bone, as well as look for the formation of new blood vessels. Legg-Calvé-Perthes disease can sometimes resolve by itself over time, so treatment is mainly conservative, involving rest, pain management, and physical therapy to preserve joint mobility. If the head of the femur is very fractured, surgery may be needed to affix braces and abduct the head of the femur to maintain its spherical shape as it regenerates. Alright, as a quick recap. Legg-Calvé-Perthes disease refers to a childhood hip disorder which occurs when the blood supply to the head of the femur is disrupted for unknown reasons, resulting in avascular necrosis of the head of the femur. Children have hip limping and pain which worsens with activity, and it may be referred to the knee. The diagnosis of this disease is mainly done with x-rays and MRI of the limping hip. Its treatment consists of resting the sick hip, having some physical therapy, and managing the pain. But also, hip surgery may be indicated.
Osgood-Schlatter disease is an inflammation of the patellar ligament, right at the point where it inserts on the tibial tuberosity, resulting in painful swelling just below the knee. It's named after two orthopedic surgeons, the American Robert Osgood and the Swiss Karl Schlatter. So, focusing in on the knee, the proximal epiphysis of the tibia, which is the upper end of the tibia that contributes to the knee joint, has a bony prominence called the tibial tuberosity. This is considered an apophysis, meaning that it's a bony prominence that serves as a site for tendon attachment. The tibial tuberosity specifically serves as an attachment site for the patellar ligament, which is an extension of the quadriceps muscle tendon. When the patellar ligament contracts, it extends the knee. At birth, the proximal epiphysis consists of cartilage, but it contains an ossification center inside. This ossification center starts to ossify, or turn to bone, between the age of 9 and 15, and becomes a bony tuberosity around the age of 18. Osgood-Schlatter disease typically develops between the age of 9 and 15, when the tuberosity hasn't ossified yet, and therefore isn't hard enough to resist traction of the patellar ligament. So this is why the disease is very common in young adolescents who play sports requiring the quadriceps muscles to contract repetitively, causing the patellar ligament to excessively strain on the not yet ossified tibial tuberosity. This results in inflammation of the ligament at the point it inserts to the tuberosity, what is known as traction apophysitis. When the traction is too excessive, it can cause the ossification center inside the tuberosity to crack into tiny bone fragments. Eventually, that results in a more prominent tuberosity or a callus during the healing process. Fortunately, Osgood-Schlatter disease resolves itself, as the ossification of the tuberosity continues as a child grows. Symptoms of Osgood-Schlatter disease are a palpable lump below the knee, which gets very painful with physical activities like running, jumping, squatting, and especially when going up or down stairs, or when the knee gets hit by something.
Ouch!
The diagnosis of Osgood-Schlatter disease is mainly based on inflammation of the tibial tuberosity, which worsens with activity. In addition, an ultrasound can show soft tissue swelling around the tuberosity, and an X-ray might show fragmentation of the tibial tuberosity in severe cases. The treatment of Osgood-Schlatter disease mainly consists of reducing physical activity and applying ice to the tuberosity to reduce swelling, as well as pain medication. However, surgery might be necessary for persisting pain, especially if fragmented bones have avulsed off and get trapped within the patellar ligament. Alright, as a quick recap, Osgood-Schlatter disease results from repetitive traction of the patellar ligament on the tibial tuberosity, causing it to become inflamed, which results in a painful swelling just under the knee. This disease typically affects young adolescents who are active in sports, and its treatment consists of reducing the physical activity, pain management, and waiting for it to heal as the child grows up. Occasionally, surgery is needed. Thanks for watching. If you're interested in a deeper dive on this topic, take a look at osmosis.org, where we have flashcards, questions, and other awesome tools to help you learn medicine. Otherwise, you can always support us by donating on Patreon, subscribing to our channel, or following us on social media.
Slipped capital femoral epiphysis is a common hip disorder in adolescence, in which the growth plate fractures. The result is a slippage between the neck of the femur and the overlying head of the femur, also called the capital or epiphysis. Normally, a growing femur has four main parts. There's the diaphysis, which is the long and hard part, also called the shaft of the bone. And that extends to the metaphysis, at the level of the femoral neck. Above the femoral neck lies the cartilaginous growth plate, also called the physis. The cartilaginous growth plate has cells which divide and enable the bone to grow in length. These cells are very active in adolescence, and they enable a growth spurt. During this period, the growth plate is relatively weak and vulnerable to shearing forces. Eventually, the cartilaginous growth plate ossifies and fuses with the epiphysis. This happens around the age of 16 in females and 19 in males. Now, before the growth plate ossifies, it's supported by the perichondrial ring, which is a dense connective tissue that extends from the metaphysis to the epiphysis. The perichondrial ring helps resist shearing forces so that the femoral head and the femoral neck don't slip away from each other. You see, the ball-shaped head of the femur comes and sits within the cup-shaped socket called the acetabulum. This makes a ball and socket type of joint, which is kept stable by a tough fibrous joint capsule and a rope-like ligament known as the ligamentum teres. The ligamentum teres arises from the base of the acetabulum known as the acetabular fossa, and that attaches to the fovea capitis, the depression found on the tip of the femoral head. Around the femoral neck, there are epiphyseal blood vessels that supply the cells of the femoral head with nourishment. In slipped capital femoral epiphysis, the perichondrial ring becomes too weak to resist the shearing forces between the femoral head and the femoral neck, causing the two to gradually slip away from each other. Actually, it's not the epiphysis that slips away, as the name of the disease suggests, because the epiphysis is well held in the acetabulum by the joint capsule and the ligamentum teres femoris. In reality, it's the neck that displaces anterolaterally and superiorly. That makes it look like the epiphysis has slipped down and backwards. If the displacement is severe, it can tear the epiphyseal blood vessels, interrupting the blood supply to the femoral head. If that happens, the epiphyseal cells can starve and start dying off, a process called a vascular osteonecrosis of the femoral head. Now, the exact cause of slipped capital femoral epiphysis is not understood, but there are some well-known risk factors like obesity. It's thought that the extra weight might increase the pressure on the epiphysis-physis junction, which can result in a slippage. Other risk factors include hyperthyroidism and a family history of the disease. When slipped capital femoral epiphysis is mild, it can cause intermittent pain in the groin, which can sometimes feel like it's coming from the thigh or the knee. This pain can worsen with activities like walking or running, and it can cause a limp. In severe cases, individuals may become unable to walk, and the affected leg may appear 1 to 2 centimeters shorter and externally rotate compared to the unaffected leg. Over time, it can also become difficult to do internal rotation and abduction with the affected leg. The diagnosis of the slipped capital femoral epiphysis requires pelvic X-rays. The X-ray is taken in a frog leg lateral view, which is where the hip is flexed and extended to help visualize the joint. The slipped capital femoral epiphysis is diagnosed when the joint space is widened and the femoral head looks displaced, most often postero-inferiorly. The treatment of slipped capital femoral epiphysis is usually a surgery to stabilize the femoral head to prevent further slipping. This is done by surgically fixing screws and pins through the growth plate to the femoral head. It requires a period of rest with limited weight bearing until the hip heals and becomes stable. In some cases, there's prophylactic fixing of the contralateral hip, even though it may look normal. Alright, as a quick recap. In slipped capital femoral epiphysis, there's a slippage between the neck of the femur and the overlying head of the femur, and it mainly affects adolescents. People with slipped femoral epiphysis present with limping and intermittent pain in the groin, which may be referred to the thigh or the knee, and in severe cases, they may become unable to walk. Also, the affected leg usually appears shorter and externally rotated compared to the normal one. The diagnosis involves taking a frog leg lateral view of the pelvis, and treatment consists of surgically stabilizing the slippage with screws that stabilize the femoral head.